Claire Walker from New South Wales, Daniel O's from New Zealand, and Matt Cannon from Papua New Guinea. The first of the presentations is Claire Walker, Keeping Them Safe at Home. Claire is the Primary and Community Care Coordinator with New South Wales Ambulance Service. Having joined that in 2005 as a paramedic, practiced as an extended care paramedic, and then moved into Clinical Services Directorate last year. She also has a background as an occupational therapist in the community and disability sector. Now, I was interested that in December 2016, the New South Wales Ambulance announced about improving links between paramedics and the GP. Recent changes to paramedic protocols provide paramedics with an intuitive and realistic treatment and referral framework. And then in a letter that was sent out just 3 months ago, there are many cases where it is more appropriate for a patient who is called 000 to be treated by their regular GP. This recognises the specialist role GPs have in the ongoing care of their patients, and in areas such as chronic disease, where a GP has good understanding of their patient's baseline presentation. In each case, the contact person that was mentioned in both the original announcement and in the letter was our speaker this afternoon, Claire Walker. Please welcome Claire Walker.
Good afternoon, and thank you for attending this afternoon's session. So the title of my presentation, Keeping Them Safe at Home, a hospital avoidance collaboration between New South Wales Ambulance and the War Memorial Hospital Geriatric Flying Squad, which is based at Waverley. Firstly, I would like to acknowledge the amazing support of Dr. Patricia Reyes. She's the staff specialist geriatrician at St Vincent's and War Memorial Hospital, Diane Gellertley, a clinical nurse consultant, and Linda Elias, who's a transitional nurse practitioner. So firstly, introduce you to an 88-year-old female, lives at home with her husband. New South Wales Ambulance received a call following a fall where the patient sustained skin tears. Denied any other injury. Further assessment identified that she had had 3 falls within 1 week. There was some memory loss identified, and she was on numerous medications. So for those with a paramedic background, 2ED or not 2ED? So if I just have a quick show of hands for those who believe that this patient should be transported through to the ED. Yep. There's no right or wrong answer. Unfortunately, the way it works in the communities at the moment and across all the various LHDs, it's location dependent. This patient, fortunately, resided in an area where there was access to a geriatric flying squad, which is a rapid response service. This patient was managed in the community. An extended care paramedic attended to this patient initially. There is a referral pathway that is in place for the extended care paramedics to refer direct through to the geriatric flying squad. And this patient was safely managed at her home. And in terms of the assessment, it was identified that she had pseudo-dementia from depression, significant osteoarthritis, it was pain, frailty and deconditioning, and multiple centrally acting medications contributing to the falls. The geriatrician on this rapid response teams rationalised her medication. She received a multidisciplinary review that included the medical review by the geriatrician, the registered nurses, the psychology intervention, social work and physiotherapist. So in this instance, yes, GP is contacted and informed of the referral. Would I, as a paramedic or as an extended paramedic, have left this patient on scene if I didn't have access to such rapid intervention? Probably not. I know that if I had referred through to the GP, the 3 falls in a week is indicative of a problem. We know within New South Wales Ambulance that we do leave a significant number of those patients who do have falls at home, and we know that they are most likely to call back. And the last thing we want is to return to this patient with a fractured neck of femur or head injury. So the Geriatric Flying Squad, based out of War Memorial Hospital at Waverley in Sydney's East, is a combination of various specialised geriatric outreach models of care which aim to prevent deterioration, reduce hospital presentations and admissions, and improve the health of older people living usually in residential aged care facilities by providing timely access to specialised aged care. Upon evaluation of this specific model at its test site, which was done in Sutherland, it was identified that this model of care is efficient and a safe service. It avoided approximately 1,350 bed days was saved, and nearly 370 presentations to hospital, with approximately a $1 million per annum costs avoided. That was based on the one at Sutherland. The Geriatric Flying Squad at War Memorial is slightly different. In addition to servicing residential aged care facilities, this same team are able to provide safe and effective clinical interventions as well to clients in the home for those aged over 65 years residing in the local community. So this is a unique model, as usually the task to either residential aged care facilities or communities. So this particular team has geriatrician, nursing, physiotherapy, occupational therapy, social worker and dietetics, clinical psychology and speech pathology. They do provide short-term case management, and they do have an average of 22 days per patient that they keep the patient on, and their aim is crisis avoidance. In terms of this particular team, of all the patients referred, not just by New South Wales Ambulance, by GPs, by residential aged care facility staffs, 62% receive full multidisciplinary input, 86% of referrals are managed at home, and of those requiring hospital intervention, 75% avoided the ED. So what was the problem that was identified? Not all extended care paramedics responding to patients within South East and Sydney Local Health District were aware of the available referral options to aged care outreach teams that may meet the needs of the patients in their place of residence rather than transporting to an ED. Previous referral pathways utilised by ECPs to aged care outreach services within South East Sydney LHD were not widely known or sustained. And in areas where we do have access to such services, we need to be tapping into them and utilising them. We do know referrals have been happening sporadically. A similar service, the South Care Outreach team over at Sutherland, over a 2-year period, reported 14 referrals from extended care paramedics. So even though we know that they are happening, these patients are not our traditional low-risk cohort suitable for non-transport. We need to make sure that if referrals are happening, we have a formal structure in place with governance to ensure that none of these patients slip through the cracks. So why is it important? We've got an 82-year-old male residing in a residential aged care facility with advanced dementia. New South Wales Ambulance received repeated calls to this patient for catheter-related issues and catheter changes. The documentation at the facility advised that the patient's catheter was not to be changed at the facility. There was issues around coagulation, as well as it was documented that a urology review was required for any catheter changes. So the extended care paramedics were unable to manage this patient at home. Most likely what was happening with this patient was they were being loaded, transported to the ED. They would do a quick catheter change on the stretcher and send the patient straight back to the facility. trying to minimise that turnaround time, as well as not actually offloading the patient into an ED bed. So this patient ended up being referred by an extended care paramedic to the geriatric flying squad. They went out to the facility, reviewed the patient, did a catheterisation history, and it was identified that this patient was lost to follow-up at a trial avoid clinic. There was no clinical reason for a long-term indwelling catheter, and there was incorrect documentation in place surrounding the anticoagulation and the need for a urology review. So what was the outcome? A trial avoid was successfully done at the residential aged care facility. The geriatric flying squad utilised their bladder scanning and continence expertise, and the catheter was removed, and this patient no longer had a need to continuously pull it out, and it decreased the problem of this patient continuously being transferred to the ED. What is concerning in addition to this is we know the associated risks, including falls, delirium, infections and functional decline with hospital presentations, as well as issues including polypharmacy and medication risks that occur during transition to and from hospital. The current process prior to the implementation of this project. The call came through to 000, an ECP was tasked to the job, assessed the patient and identified that the patient, it was not immediately time critical, and it can and should possibly be able to be managed either through the GP or an alternate care provider. They resort to their folder of documentation to try and identify what referral options are available in their area. This information may not necessarily be up to date, or they may be in an area which is not local to them. Unsure what to do with the patient ends up in the emergency department. Current research suggests that up to 70% of hospitalisations for specific conditions may be avoided with well-targeted interventions and timely access to the required specialists, which may include geriatricians, nurse practitioners, CNCs and allied health. So why was there a need to formalise these pathways, and why were they not being sustained over the years? It was identified that the pathways were informal, and it's not just localised to this area. We know the pathways were reliant on local knowledge, word of mouth. It may be the community nurse speaking, having a chat with one of the paramedics and say, you know, this is what we can do, start referring to us. Brochures kept in folders within the vehicles were not current, and pathways and referral criteria were not documented. Executive support across both organisations had not been sought, so it was done at the ground level, and with the transitions of staff, we know with the paramedics they're moving on and off the rosters, and within health they move. So it comes time for referral, and no one knows what an extended care paramedic is, and the ECPs don't know what's happening within that particular service. So with any good project, you need to have a good driver diagram. The primary drivers, I'm not going to go too much into it, but the primary drivers were the need to increase formalised pathways, enabling the ECPs to refer to the outreach services rather than the ED, to improve communication between the LHD outreach services and ECPs with pathways sustained for more than a year, improve ECP knowledge of the role, scope and referral process for outreach services, and increase safety of ECP referral process to outreach teams, and to ensure the pathways were sustained. So we knew we wanted to move ahead with standardised templates that have the role, scope and referral process clearly documented. We knew that we needed to spend time on education sessions to inform ECPs of the role and scope of the services, and that's inviting the outreach teams to come and meet with the ECPs, and also we're having the outreach teams do ride-alongs with the ECPs. And ECP champions to assist in pathway development and implementation. If they're part of the process, they're more likely to own it and help sustain it in the long term. And put in place quarterly processes that reviews the templates every 3 months. With the services, maybe hours, it may be the contact details for referrals, it may be that they've lost a particular staff member, so we can't refer for specific conditions. So having that 3-month process just ensures the information is up to date. So with the War Memorial Hospital, our collaborative aim statement was using the principles of integrated care, further prevent unnecessary ED presentations and improve outcomes for older persons by developing a formalised, streamlined and sustainable referral system between New South Wales Ambulance ECPs and the Geriatric Flying Squad War Memorial Hospital. So we obtained the executive support and met face-to-face with each of the clinicians within the services. Collaboratively, we developed mutually agreed inclusion-exclusion criteria and a referral process that was necessary to ensure that a well-coordinated response was followed and decrease the risk of any adverse effects. This is the War Memorials. This is a generic standardised template that we are now using for all alternate referral destination pathways. At the top section, it includes a brief summary of the particular service that we're referring to. We've got eligibility criteria, and in this case, we've got criteria specific for the community and criteria specific for residential aged care. We've got our exclusion criteria listed and conditions that may be appropriate for referral. We've got the contact details, the hours, and the particular suburbs, or in some cases residential aged care facilities, where they will outreach to. So for the extended care paramedics, conditions that may be appropriate for referral. What is important to remember here is that the types of referrals we're putting through to this geriatrician need to be conditions that are appropriate for them to manage. In the first instance, it should be managed, certain conditions should be managed through the general practitioner. So we're not skipping the general practitioner. It's only when we know that the general practitioner wouldn't be able to manage it in a timely manner that we refer through. And it's also a next step that we've moved to for paramedics in terms of increasing the risk of the types of conditions that we are managing in the community. So extended care paramedics can provide oral antibiotics in the first instance. So if they went to this particular person, they would manage them as normal, provide the oral antibiotics for wounds, urinary tract infections, cellulitis, and that patient would then get managed as normal through the general practitioner with the follow-up. And it's referring to the Geriatric Flying Squad for conditions where they need IV antibiotics through the hospital in the home. Additionally, referring for pain management review when the GP cannot provide it in a timely manner. Palliative care patients for pain management, symptom management. Fevers responsive to antipyretics. Falls without the possibility of fracture or head injury. Increasing confusion and delirium. And this is one that tossed and turned with. This is what the geriatricians and these teams are telling us that they want us to refer. But at the same time, that's a big risk for us in managing these patients. Additionally, you've got another area which has the same model where the geriatrician is saying no. Increased early delirium, we want it managed in the ED with a full workup. Whereas we've got other geriatricians saying that no, we can do the same workup in the facility safely and manage this patient within the ED, within the residential aged care facility. And yeah, urinary tract infections, upper respiratory. So it is the moving to that next step where IV is required. The concern in opening up this pathway to all paramedics is that if they can't provide the oral antibiotics or that first step, they can't do the catheter changes, they can't do the peg changes. We don't want these specialised teams doing the job of the general practitioner and then not being able to be a rapid response. They'll end up with a waiting list of a few days, which for a paramedic, for an extended care paramedic on scene, what we need to know is how soon that team would respond. So if I had a patient with the signs of early delirium or early sepsis, and they said, yes, we're going to get in the car, we'll be here in 40 minutes, and I know it's a geriatrician attending with a nurse practitioner, I would be comfortable in managing that patient through that process. But if they said to me, no, it could be tomorrow or, 48 hours, that patient would be transported to the ED. So we've had 15 patients referred by extended care paramedics up until June this year. The number of comorbidities of those patients, the average number of the comorbidities of those patients referred was 6.6. So they are complex patients. Of the patients referred, 11 were managed at home. One patient was referred direct up into the rehabilitation. 2 patients went to respite, and 1 patient, due to being unable to manage their pain, was referred direct to the ED. Of those referred, we've got 7 patients who received multidisciplinary review. 5 were the reason for referral was falls, and some of these have multiple reasons for referral. We've got advanced care planning, wound, 1 patient for wounds, and catheter or peg tube issues. So within southeastern Sydney, War Memorial is one, based out of War Memorial Hospital. We've also got Sutherland and St George, which offer similar services. They've got 2 services each. One's for residential aged care and one's for community. So towards the end of last year, we set up meetings with each of those services, so the integrated care manager for southeastern Sydney LHD, and we've now formalised pathways with each of those services. So following the formalisation, as you can see, we've had a steady increase in the number of referrals that the paramedics have been referring through. The benefits. So we know it leads to improved outcomes and decreases the risks associated with presentations to ED and hospital admissions. We've got these patients being managed in their own environment, and it's conditions that previously we had no other choice or options but to send to the ED. It avoids the non-geriatric friendly ED, it streamlines case coordination, it fills in the gaps. Referring through the My Aged Care can be 6 to 8 weeks minimum before that patient may receive a comprehensive assessment to identify their needs or their funding requests. So if we needed an occupational therapy review because we know that patient's risk of falls and their environment's not set up appropriately, it could be 3 months. It's improved the communication between both service providers. We are aware of the patient outcomes. We've facilitated ride-alongs, the clinical education days. New South Wales Ambulance now have representation at the aged care provider meetings in each of the areas, and it provides a phone a friend clinical advice prior to referral or for patients where we're just not quite sure, and we can have that discussion with the geriatrician. Moving forward, we need to look at satisfaction surveys, patient carers' satisfaction, and referrer satisfaction, provide a closed-loop referral system. What is good about this system is that we know if a patient, say a patient was referred and then they end up being inappropriate for that service and sent to the ED, we know about that. At this point in time, if we opened it up to all paramedics, we won't be able to, we've got nothing in place currently to monitor these referrals, to know if the appropriateness of the referrals. We'll be looking at hospital bed days saves, the morbidity and mortality rates, representation rates to New South Wales Ambulance, readmission rates to ED. We need to look at the ECP on scene and case cycle times, particularly before we open it up to the broader paramedic group. Increase the response of ECPs into residential aged care facilities where such referral opportunities exist, and develop scope and governance process to enable the pathway to be opened up safely to the wider paramedic cohort. We need to move towards electronic templates to ensure that paramedics are referring to the most current referral criteria and details. So those orange templates are currently a hard copy, and we will be having the most current version available on the intranet. And electronic referral to improve patient safety and the continuity of care through a streamlined and transparent process. Thank you.